Oxygen important in wound healing. Can you take us through some of the reasons and where oxygen plays a role in wound healing?
Sure. Well, oxygen is important in all phases of wound healing, really, from just the mere fact that cellular metabolism is dependent on oxygen. When the tissues are injured, the metabolic demand increases and the oxygen requirement can increase. Collagen production itself for wound repair and forming the basis of angiogenesis is itself an oxygen-dependent process. When oxygen levels are low, it's been quite well demonstrated that collagen production decreases, and there's a lot of factors for that, as you can see on the slide. And then there's a whole arena of activity going back to T.K. Hunt and Knighton, showing that antimicrobial activity is very oxygen dependent, and leukocytes don't function well in a hypoxic environment.
Absolutely. So when we have arteriovascular compromise, this basically summarizes what you just told us, Jack. We then lead to tissue hypoxia, which is due to compromised oxygen supply. That hypoxia then leads to these wounds that don't heal. So how do we address this oxygen deficit? And there's a number of ways that we can do this. Certainly we can maximize vascularity. These patients that have disease, that have stenosis, can be treated with angioplasty or revascularization attempts. We can decrease tissue edema, and again we suggested that if we can decrease the tissue edema, we can decrease the extrinsic compression on these blood vessels, enhancing distal blood supply. We can certainly decrease tissue demands by controlling infection, decreasing bowel burden, decreasing and lowering those metabolic demands. We can maximize delivery, making sure these patients are well hydrated and that they're not anemic. And then, Jack, finally the last one, and our favorite way of reversing oxygen deficit.
All right, increase oxygen delivery to the tissues by providing extra oxygen.
Absolutely.
In our case, hyperbaric oxygen therapy. I think it's important to point out that we like to do as many of these as possible too, not just pick one or even two, but try to hit the system in as many ways as we can.
Yeah, I think you need to certainly address vascular maximization first before you get start thinking about hyperbaric therapy.
Right.
Well, there are a number of advanced modalities out there when we start talking about adjunctive techniques for maximizing oxygen tissue. And let's talk about two of them. We had suggested hyperbaric is one of those. Another of our favorites is the use of vacuum-assisted closure therapy. Now let's look a little closer at these two modalities. Certainly, I'm going to suggest to you through the rest of this presentation that VAC therapy as well as hyperbaric oxygen therapy can have a role in healing these chronic wounds. First of all, let's start off with some definitions. By now you're all experts on how VAC is utilized, what it does for you, but a real brief summary. We oftentimes define VAC therapy in these terms: an active wound dressing utilizing controlled negative or subatmospheric pressure that's applied to the wound base through a porous sponge, and it can be delivered in either constant or intermittent fashion. And here you see a little cartoon again that you've seen before, that this VAC sponge does certain things to the wound, causing certain dynamics, and the whole goal here of is enhancing healing. If you look to the literature, there's 4 mechanisms that are reported when we start talking about the effect and mechanisms of VAC therapy: a vascular mechanism, an infection control mechanism, mechanical and chemical mechanisms. Switching gears and defining hyperbaric oxygen therapy, I think oftentimes it's important to define what hyperbaric oxygen therapy is not.
Right.
First of all, it is not the oxygen extremity chamber.
Topical oxygen.
And it's not the oxygen boot bag or the oxygen butt bag.
Not the butt bag, Bob.
No, not the butt bag. How about this, Jack?
The body bag?
The body bag. Is that hyperbaric?
No, absolutely not.
Absolutely not. These extremity chambers and these topical oxygen devices miss the definition of hyperbaric for 2 reasons. First of all, they're not inhaled, systemically delivered oxygen, and also these devices never achieve any significant degree of pressurization. The pressure achieved by the extremity chambers rarely exceeds 1.03 atmospheres. Hyperbaric is defined as inhaled 100% oxygen delivered to the patient while that patient is entirely enclosed in a pressurized systemic environment. And we typically will treat at pressures of 2.0 to 2.4 atmospheres, sometimes 3 atmospheres. So you can see there's a significant difference between what we can achieve in the hyperbaric environment versus what can be achieved by those extremity chambers. Let's look a little closer at the mechanisms of action. using an example of a patient at sea level breathing air, you see that all hemoglobin sites are bound. We carry very little oxygen actually physically dissolved in the plasma. Breathing air at sea level, 1 ATA, only about 0.3 volume% of oxygen is dissolved in the plasma. However, when we take a patient at 3 atmospheres, put them on a 100% oxygen, you can see from the cartoon we do not at all change the binding of the hemoglobin sites. What we are able to achieve is dissolving a significant amount of oxygen into the plasma, a tune of 6.9 volume%. Now this is enough oxygen to actually sustain life in the absence of hemoglobin. If we look more mechanistically at what happens, again our example of a patient breathing air at 1 atmosphere, see the PaO2 is about 100 millimeters of mercury. That oxygen is able to diffuse out to a radius of about 64 microns. The numbers are somewhat less on the venous side. Let's take that patient at 3 atmospheres, put them on 100% oxygen. You can see how quickly the PaO2 values rise to significant levels, but more importantly, that diffusion gradient, just by putting extra oxygen into the plasma, is able to diffuse out through pure physics to now a 5-fold increase in the diffusion radius, reaching those marginal tissues that are otherwise poorly perfused and hypoxic. Again, the numbers are somewhat less on the venous side. Jack, this is a slide, an old slide, but I think it's an important slide, and it reminds us what actually happens to the patient in the chamber.
Sure, this is from Strauss, showing both the amount of oxygenation within the blood, that's the high loop that you see there, and that's relatively short-lived.
And that basically is for the 90 minutes they're in the
Right,
chamber.
that's the treatment time. And then the 2 other curves showing the muscle and the subcutaneous tissues emphasize the fact that although it does take a little bit longer for the oxygen levels to rise while patients are in the chamber, the oxygen also is maintained at a relatively high level for some period after the treatment. So there's some longer duration of the effect than just the simple duration time, up to about 4 hours is usually
So those slower
quoted.
tissues off-gas over a longer period
Right,
of time. So
right.
really, even though they're only in the chamber 90 minutes, they're getting hyperoxygenation of the tissues for 3 to 4 hours.
Right.
Absolutely. Let's take a quick tour and see what would happen when a patient visits our hyperbaric chamber on a daily basis. You can see our chambers we commonly refer to as Bonnie and Clyde. Clyde's our critical care chamber. When a patient comes in for a treatment, they will change into cotton clothing for safety purposes. They're then greeted by good-looking, intelligent physicians.
Well, sometimes they are.
The ambulatory patients will walk into the chamber and have a seat in the chair. We also treat gurney patients, and you can see the gurney being loaded into the chamber.
Watch your head.
Once they're inside the chamber, they're placed on oxygen masks, although some chambers do deliver oxygen by hood, and then the monoplace chamber is pressurized entirely with oxygen. During the entire treatment, they're monitored by technicians, and following the treatment, the patients disembark, and you'll notice that patient exiting with what in his hand?
Looks like a V.A.C canister.
Can you really do V.A.C and hyperbaric together?
It's been known to happen.
We should talk about that.